This lecture is about portal hypertension by Dr. Hisham El-Akkad, Professor of General Surgery at Ain Shams Medical School. By the end of this lecture, you should be able to preliminary diagnose patients with portal hypertension from clinical picture, request the proper investigations and explain the value of each, differentiate between patients who need medical treatment and those who might need interventional measures, including surgery. Discuss the lines of management of GIT varices in particular, and decide for the proper line of management of portal hypertension and state its principles. Prehepatic causes are due to congenital atresia in neonates or portal vein thrombosis in any age. Most common causes of portal vein thrombosis are abdominal sepsis and trauma. Examples of sepsis leading to portal phlebitis and thrombosis are acute appendicitis and diverticulitis. Hepatic cause is mainly cirrhosis, which is the most common cause of portal hypertension in general. Other hepatic causes include chronic active hepatitis and periportal fibrosis of schistosomiasis. Post-hepatic causes are Budd-Chiari syndrome due to hepatic veins thrombosis, constrictive pericarditis, or tricuspid valve incompetence. Hematemesis is life-threatening and may originate from esophageal varices or from gastric fundic varices. Reversal of flow from portal side to systemic side occurs through the left gastric vein in esophageal varices and through the short gastric veins in fundic varices. Ascites may not be from portal hypertension alone, but also due to associated liver dysfunction. Splenomegaly may be of huge size and results in hypersplenism. Liver cell dysfunction occurs in hepatic and post-hepatic portal hypertension. Cirrhotic patients with portal hypertension are classified for severity by the Child-Pugh classification. This classification is used for deciding appropriate lines of treatment, including transplantation, as well as for treatment of other diseases in association with cirrhosis. For example, in a patient with symptomatic gallstones and child B or C cirrhosis, cholecystectomy is best avoided unless complicated. This is in contrast with non-cirrhotic patients or child A patients with symptomatic gallstones where surgery is indicated. The application of this classification to clinical situations will be discussed more with liver diseases. Liver function tests should be done in all patients with portal hypertension. Abdominal ultrasonography shall diagnose macro or micronodules, hepatomegaly or shrunken liver, splenomegaly, and ascites. Transabdominal Doppler ultrasonography measures the caliber of the portal vein. It is dilated in hepatic and post-hepatic types. Portal vein thrombosis could be diagnosed, and it also measures the blood flow in both portal and hepatic veins. CT is done to assess the cause, like in portal vein thrombosis due to abdominal sepsis. Upper endoscopy for screening for varices and possible banding or injection sclerotherapy is mandatory once portal hypertension is diagnosed. Budd-Chiari syndrome of moderate severity is managed by anticoagulants. Severe impairment of hepatic outflow needs shunting by transjugular intrahepatic portosystemic shunt known as TIPS. Portosystemic shunt operations are rarely done now in favor of liver transplantation, except in rare occasions of severe hematemesis where other measures fail. Splenectomy for hypersplenism secondary to cirrhosis is uncommon at present, except for severe bleeding tendency and huge spleens. Portal vein thrombosis is managed primarily by dealing with its cause, anticoagulants, and awaiting recanalization. Most ascites is controlled by potassium-sparing diuretic spironolactone. For tense ascites causing respiratory distress, tapping of the ascites is done gradually. Hypoalbuminemia aggravates ascites and needs correction. For non-bleeding varices, application of rubber bands by endoscopy around the varices is now the treatment of choice. Complete ablation of the varices usually needs repeating the procedure on intervals of about 3 to 6 weeks. Later, yearly endoscopic follow-up is needed for any newly developing varices. For bleeding varices, the usual treatment is sclerotherapy, although banding is also possible or a combination of both. Sclerotherapy is done by injection of thrombotic material endoscopically through an endoscopic special needle into the bleeding vein or around it. This is called intravaricial or perivaricial injection sclerotherapy. An oily substance like ethanolamine oleate is commonly used. Fundic gastric varices are usually managed by endoscopic injection of a tissue glue like cyanoacrylate inside the vein. The procedure may need repetition after about 6 weeks for unobliterated portions of the varices. Transjugular intrahepatic portosystemic shunt, known as TIPS with one S or two S's, is the insertion of a stent through the right internal jugular vein through the superior vena cava, then the inferior vena cava, then one of the hepatic veins through the liver down to a portal vein. The stent is left between the portal vein and the hepatic vein. Surgery is done in variceal bleeding when other methods fail. Esophageal transection at the gastroesophageal junction with reanastomosis to the stomach is done using a circular stapler. The submucosal connections between the esophageal veins and the left gastric vein are then interrupted. Other option is to do a portosystemic shunt like anastomosing the splenic vein to the left renal vein, an operation called Warren's operation, or to do a Hassab operation. Dr. Muhammad Abul Futuh Hassab, an Egyptian surgeon, described his procedure of doing splenectomy with devascularization of the lower esophagus and upper stomach. Another type of operation is to open the lower esophagus and upper stomach by a longitudinal incision and suture the bleeding vessels. All types of operations done in this emergency situation are attended with high mortality due to the massive blood loss and poor liver function in most of those patients. Other less common sites of varices include the duodenum due to shunting between the pancreaticoduodenal veins and the systemic retroperitoneal veins, also in the rectum due to shunting between the superior hemorrhoidal vein, also known as the superior rectal vein, and the systemic pudendal veins. Thank you, and please be ready with your questions in the face-to-face session. I would like to remind you that there is another recorded lecture about splenomegaly and hypersplenism.